Welcome to the University of Toronto Joint Center for Bioethics Seminar Series. I'm Angel Petropanagos, and I'll be the moderator for today's session. Our speakers are Dave Langlois and Jeremy Butler, and their seminar is entitled The Scope of Clinical Ethics, Letting Go of Moral Distress. Before I introduce today's speakers, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Center for Bioethics website. The format of our seminar is a presentation by our speaker, followed by a facilitated discussion period. First, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now, it is my pleasure to introduce today's speakers. Dave Langlois is a clinical ethicist and the director of the fellowship program at Unity Health Toronto. And Jeremy Butler is an ethicist in Kingston, Ontario. He's also an adjunct instructor in the Department of Biomedical and Molecular Science at Queen's University. So welcome, Dave and Jeremy. Thank you. I will turn it over to you.
Thank you, Angel. Thanks very much. And thanks everybody for having us today. Jeremy, we don't have any slides about disclosures or a preamble or anything like that. I guess maybe what we could do is just apologize for this not being better, because we were going to make it better, but then we weren't able to. So apologies for that.
You know, that's a good start, Dave. And it's true, we don't have any preambulatory slides of that nature, but maybe just say a little bit about before we kind of get to the substantive content of the overview where we're going to go, just a little bit about where this presentation came out of. Dave and I are both work as clinical ethicists, and in fact, Dave was my teacher when I was a fellow in clinical ethics at the CCE, where Dave still is. And we've definitely had conversations and talked a fair bit about kind of the role of moral distress in the practice of clinical ethicists and the sort of the character of discourses about moral distress in healthcare organizations. And so that's kind of some of the thoughts we've toyed with over the last little while are what we're trying to put in a structured or coherent way in this particular talk. And so we're hoping for feedback on this stuff. We look forward to hearing what people have to say about it. This is kind of a preliminary shot at giving some of our inchoate thoughts a bit of a structure.
And one thing maybe to add there is that as this, in a way, some of this is critical of certain ways of doing or claiming to do clinical ethics. But I would say from my own perspective, I think from Jeremy's, I admit with some trepidation, but also wholeheartedly, like that a lot of the things that I'm criticizing are things that I have myself done or caught myself saying or claiming that I do or could do or whatever. So this is not us finger wagging at anyone else in particular. But it is at times critical. So we're gonna begin by just saying what we're claiming in the presentation, and then what we're not. We're going to talk about the original and maybe a modified or revisionary concept of moral distress in the literature and in clinical practice, and then we're going to make two parallel arguments: one a conceptual argument, one a practical argument concerning the relationship between moral distress and clinical bioethics. And then we're going to talk about what we think, if there is a legitimate role for clinical ethics in dealing with instances of moral distress at the clinical level, what the role of an ethicist might be, and then maybe very briefly step back to talk about a general problem about scope in clinical ethics practice. One thing that we wanted to say before we start is if anybody has questions, we're happy to answer them as we're going. So please, if you do have a question, type it at any time. We'd be only too happy to get away from our ugly and underdeveloped slides and engage with something thoughtful that somebody says. So with that, we're off to the races.
So yeah, just to get clear on, because as Dave said, we're going to be saying some stuff that is in some respects critical about aspects of the practice of clinical ethics, or sometimes the way clinical ethics is sort of represented as a discipline or a role within healthcare organizations. We take ourselves to making a pretty specific and narrow claim, which is that clinical ethicists don't have any sort of discipline-specific expertise. So that is, they don't have any specific expertise in virtue of being clinical ethicists in directly responding to, that is, managing or mitigating or alleviating clinicians' experiences of moral distress at the clinical level. So we're making quite a narrow claim about a certain element of expertise that clinical ethicists don't have or shouldn't necessarily claim to have. Now, to be clear, we're not claiming, we're not going to be saying that clinical ethicists don't have any role in addressing the sources of moral distress in many cases. And we're certainly not saying that clinical ethicists should be unwilling to engage with clinicians about their experiences of moral distress. We think that clinical ethicists, like all good colleagues, should be willing to sort of offer collegial support and be available for discussion and conversation about things that are troubling their colleagues at work.
And maybe if we had decided to do a better presentation, we might have said why it is that we're saying these things. And of course, and we'll get into this a little bit later on, but it's of course because certain clinical ethics services or centers, not just locally, but nationally and internationally, advertise themselves as being able to deal with and manage clinicians' moral distress at the clinical level. And admittedly, this is something that I have occasionally found myself doing or claiming to do in the past as well. And we think that that's not a super great idea. And so that's what the presentation is about. All right, so we'll start off just by an apologies for rehearsing very old stuff from the literature about what moral distress was purported to be in the early days. And we actually think one of our contentions is that these early definitions are actually very useful and shouldn't be forgotten. Sort of the first definition from the very early 80s, when I was one, was that moral distress is the tension one feels when one knows the right thing to do, but institutional constraints make it nearly impossible to pursue the right course of action. So we'll draw your attention a few moments to the sort of the normative and cognitive and emotive or psychological aspects of this. But there's some kind of judgment about, a factive judgment about, at least in the early definition, a true judgment, since it's knowledge about what the right thing to do is, with a belief about there being institutional constraints that make it impossible to pursue the right course of action, and then the tension or the accompanying feeling of that. That was the earliest definition of what moral distress was, at least in the nursing literature. And then 10 years later, there's a modestly revised definition that says that moral distress is the tension one feels when one makes a moral judgment about a case in which he or she is involved and the institution or coworkers make it difficult or impossible to act on that judgment. So there's a slight revision there, because here in Jameson's sort of revised definition, the moral judgment doesn't necessarily constitute knowledge, and that's not an insignificant change. So one has to, and I think it's because one's moral judgment could of course be false, but in the revised definition, one has a moral judgment, and then either there's some external structural impediment that makes it impossible to act on that judgment.
So those are the kind of, I think, it might be right to call those the canonical or the original or the earliest sort of clear statements of the phenomenon of moral distress in Jameson. And we want to highlight what we take to be kind of the three central components of moral distress on that concept. So as Dave kind of suggested, moral distress includes a normative judgment about what ought to be the case, right? So it includes a judgment that there's something amiss in the circumstances in which the clinician is experiencing the moral distress, right? There's a moral problem that, if it were possible to change, ought to be changed. It also includes an associated cognitive state, a judgment about what is in fact possible to do in the morally undesirable situation, right? So if you're going to be in moral distress in the Jameson sense, you've got to also judge that the options that are available to you are insufficient to address the normative problem, insufficient to address the moral problem. And in fact, it includes a judgment that there is no acceptable way to address the normative problem from the position that you're in as a clinician. So for whatever reason, doing the right thing is unavailable to you within your role. And of course, it also has to include a distress component, right? So moral distress on this conception involves an accompanying or an associated emotional or psychological state of distress that I think importantly is supposed to be understood to flow from the two judgments, right? So we've got a normative judgment about what ought to be the case, but is not the case. We've got a cognitive judgment about about what options are available to us to address the normative or moral problem. And when we pair those together, we get a state of psychological or emotional distress. And I think it's important to highlight, as Dave, you kind of said on the last slide, that these are all set against the backdrop of kind of like almost an objective component of moral distress, which is that the situation really is more or less as you judge it to be. So there really is no readily available option to address the underlying moral problem. But I think you also want to speak to the relationship between moral hazard and moral distress on this concept.
Yeah, I was just gonna, I mean, historically and in the literature, there was recognized to be a relationship between typical instances of moral hazard, where the locus of moral responsibility and the structures of the institutions or parties that generate a moral burden are distanced or insulated from that risk or that burden itself. And because that can serve it as at the very least, a negative incentive to not address whatever the problem is, right? So, and this happens in healthcare all the time. There are laws or funding issues or institutional constraints or pathways, whatever. And the sort of power holders, the individuals who make the decision are at a certain level. They're not the ones who shoulder, or they're insulated from the risk or the moral burden at the individual or the clinician level. And because they're insulated personally from that risk or burden, they don't have, they're not appropriately incentivized to address what those structural problems are. And this is the canonical circumstances in which moral distress occurred and occurs on the traditional definition of moral distress. It's precisely the fact that one, from the bedside, as it were, is not able to address the structural problems. It's because of that one winds up in this bound in this situation where they can't do the right thing. And that was, again, traditionally what was responsible for creating moral distress. Then in recent years, so in the last 20 or 30 years, moral distress is now used in much broader terms. We're not going to work through all these definitions here, but I think the idea is that if you take a glance at the literature more recently, people use moral distress to mean a whole bunch of different things. From, on the one hand, something that approximates the original definition of moral distress to like feeling bad about moral stuff or whatever, like, being in a situation that requires a moral resolution and the like moral weight and the emotional weight that goes along with it. The term moral distress is now used much more broadly than it was originally intended to be used. And I guess we don't necessarily think that's a great idea.
I think it's interesting to note, David, that even in the two Jameson formulations, the early ones, as you note, in the modestly revised definition, it's already moving away at that point from the sort of strict definition, right?
Yes.
So it starts off where it's nearly impossible to do the right thing, and then it's where institutions, of course, make it difficult or impossible. So there's this kind of almost, I mean, that's not immediate, what's that, 9 years, but there's this discernible trajectory in understandings of moral distress from a quite restricted, narrow conception to a much broader and less clearly defined conception.
Yeah.
So Jeremy, David, I just want to point out, we've got a comment in the chat on YouTube, and someone points out that in this pandemic, many families were confronted on their values because institutions had to follow procedures in the state of emergency. So that, I guess, in this context, it's not a theory, that we've got some examples from the last year.
Mm-hmm. Yeah, I mean it's absolutely the case that that the pandemic sort of threw into relief some of the difficult moral situations into which clinicians and other workers in healthcare get put as a result of structural factors and found themselves having to do very difficult things. There's no doubt about it.
But I guess what we just wanted to highlight is that there's been a really considerable shift from the narrow traditional definition of moral distress that had an association with moral hazard and towards this much broader use where it kind of means like being distressed about something moral, which again, in terms of what the words moral and distress mean, somebody could be forgiven for using moral distress to mean distressed about something moral. So fair enough, but it is a different concept. And I think one of the things we're going to go on to talk about is that that matters. Maybe you can say why it matters, Jeremy.
Yeah, no, so you're exactly right. What we want to highlight is the difference between the original sort of what we'll call going forward the traditional concept or traditional definition of moral distress, where it really highlights the distress you experience when you're in a morally fraught situation and there's really nothing to be done about it, and this much more expanded sense where it refers to sort of any unpleasant feelings that accompany the judgment that you're in a morally fraught situation and something needs to be done. So the two problems that we want to highlight here, one is conceptual and one's practical. So the first one is just that we think that the original, for lack of a better word, stricter or more narrow definition, the traditional definition, is a really useful and important one because it highlights a moral phenomena, or pardon me, it highlights a type of phenomenon that does have a kind of special moral significance, right? It's the phenomenon of healthcare systems and structures systematically obstructing clinicians from doing what they perceive to be the right thing, and in many cases, what is in fact the right thing to do. So we think that concept is worth hanging on to for its own sake. And sort of setting that aside, regardless of where we land on the concept of moral distress, we also think the expansion just leads to conceptual messiness, and it leads us to I think certain ethicists sometimes, but also all kinds of other stakeholders in the health system, not really always being clear on what we're talking about when we talk about moral distress. So that's the conceptual problem, and we're going to talk about that in a bit more detail. But we also think it leads to a practical problem, and just to anticipate is that the equivocation or the sort of looseness of the expanded sense of moral distress creates confusion about how, like in what ways and whether and to what extent clinical ethicists have a sort of specialized particular role to play in directly responding to clinicians' experiences of moral distress.
I don't think we need to even hang on this for too long because we rambled about it before, but so why not abandon the original traditional definition of moral distress? I think we both said why we think it's important, especially in light of the tie to moral hazard. And as you just said, I mean, there are lots of well, I think the pandemic is an interesting example. There are lots of circumstances where structural problems are responsible for the distress that individuals feel at the clinical level. And losing sight of this concept in favor of just using the phrase moral distress to mean like times where you're distressed about something that's moral, we think it can kind of serve as a distraction that takes our focus away from what the appropriate ways of alleviating actual or dealing with actual moral distress are. An aside here about resiliency. So we think, so for example, consider all of the time and attention, focus, energy, money that is now put on quote unquote resiliency training for direct care providers. We think that the plausibility of it being useful or maybe a good primary focus to focus on resiliency is in a way created or at least helped by the conceptual messiness. If we were being really honest with what the sources and potential cures for moral distress, which are systems level, then probably it would not be as attractive to try to deal with them through clinical level interventions of like teaching people to like grow thicker skin or whatnot. So we kind of think that there's a possible problem in having our attention taken away from the original definition. So
that's the conceptual problem, and as I say, we won't linger on that one quite as much, but happy to talk about it more if folks are interested. But the practical problem we wanted to highlight pertains specifically to the discipline of clinical ethics. And it's our thought that the conceptual messiness involved in the new expanded sense of moral distress leads to uncertainty about the proper role for clinical ethicists in addressing moral distress. So as Dave said at the outset, it's reasonably common, and we think folks working in the discipline will probably recognize this, that many ethics services, certainly in Canada, represent themselves as available to address clinicians' moral distress, and not just as available, but sort of represent one of their key roles as addressing moral distress on the part of clinicians. Now, we did a kind of an informal scan of ethics services web pages across the country, and again, it's just informal, not systematic, but this is not uncommon, and you might even say it's the norm. So we think that this is a little bit problematic, or it can be problematic, because if we understand moral distress in the traditional sense, or remember in the narrow sense that focuses on structural barriers to acting rightly, then we actually think that clinical ethicists acting at the clinical level have a very, very limited role to play in directly managing or responding to the moral distress of clinicians. Now, we think that if moral distress is understood in the much broader, the more permissive sense, then we think the role for clinical ethicists expands somewhat, but we also think there needs to be recognition of some important limitations to that role. So that's what we want to talk about now.
So looking briefly at the traditional definition of moral distress, it's in light of the sort of tripartite structure, it's pretty obvious the three possible routes for addressing an instance of moral distress. So if moral distress is constituted formally by a normative judgment, a cognitive state, and an accompanying emotional or psychological state, you can address somebody's moral distress by changing any one of those or more than one of those three things. So you could change somebody's mind about a normative matter. You could help them come to either appreciate new options, or as above, the acceptability of one of the options that they believe is available, or you could somehow directly intervene on the emotional or psychological state of distress and make them feel better through that direct emotional or psychological intervention. Interestingly, and obviously, again, we don't have like data or something like that, casually, it seems to be the case that in some parts of the world, clinical ethicists and clinical ethics services kind of advertise themselves as somehow able to do that sort of emotional or psychological work. Again, I've probably been caught offside before pretending that something I might say would be able to play that kind of role. But one of the things that we want to talk about is whether or not it's plausible or appropriate for us to be claiming to be able to do any of these things.
So first, with respect to the idea that there might be clinical ethics interventions that either change people's normative judgments in order to alleviate moral distress, or change their beliefs about the moral acceptability of the options that are available to them. So we definitely think that it will sometimes be the case that after an ethics consult, or just a good sort of rich discussion with an ethicist, a person experiencing moral distress may change their normative judgments in a way that dissolves that distress. But we don't think that this should be, in any general sense, the goal of clinical ethics interventions. And there are a couple of reasons for this. One is it risks clinical ethics adopting a kind of status quo defensive approach, right? So we wouldn't want clinical ethics to be a discipline that aims to change people's minds about moral matters whenever their beliefs about moral matters are causing them distress, right? This would not be a good way of going forward, particularly if and when people's moral beliefs are actually right? Particularly when they're right about the moral question issue. We don't want to change their mind just to address the underlying distress. And the other reason why we don't think we want to rely on this is that even if a clinician experiencing distress has a good discussion with an ethicist, and that leads her to adjust her normative judgments or her beliefs about the moral acceptability of the options, that's not necessarily going to be the result of the exercise of discipline-specific expertise on the part of a clinical ethicist, right? It's possible that it may be in some cases, but it's not necessarily, it's certainly not the case that what clinical ethicists train in is specifically persuading people to change their minds about moral matters.
At least we hope not. It's not a good idea.
And I think in this context, we also just wanted to think it's worth emphasizing that if we're being sort of like, if we're strictly adhering to the traditional narrow concept of moral distress, then again, on a strict reading of moral distress situations, it's really like the point is supposed to be that there's not really anything that can be done at the clinical level. So the idea that clinical ethics interventions could address moral distress in that sense by changing people's mind about the accessibility of the options suggests, again, like it would be, it's not something we want to be doing, trying to convince someone that the options available are morally acceptable, when if it is in fact moral distress, the point is supposed to be that they're not.
And of course, we're admitting there can be circumstances where people have false or silly moral beliefs, where there's good options that would even satisfy them if they knew about them or whatnot. But this can't be what the discipline hangs its hat on in terms of managing moral distress. It can't be that what we claim to be able to do is go in and revise people's moral beliefs or help them appreciate new options, although sometimes that could be the case. So then this brings us to the third way that one might manage or mitigate one's instance of moral distress at the clinical level, and that would be by direct intervention on the emotional or psychological state of somebody who's experiencing moral distress. I don't know if anybody ever explicitly says that this is what they're doing, if they're doing like a moral distress debrief at their institution or anything like this. I doubt it's ever, the point is ever made that baldly, that like what we're going to do is like intervene on your emotional or psychological state to alleviate the feeling of distress. But it's hard to sometimes otherwise understand what the claim is that one would be doing if it's not that you're doing the other things that we just said that hopefully we're not doing. Now, important point, there may be people who are acting as clinical ethicists who for independent reasons are able to do this kind of counseling work, for lack of a better word. But if they're able to do that, then they're not able to do that because they're a clinical ethicist. There are clinical ethicists who can perform surgical procedures, who maybe they're registered clinicians and registered with the capacity assessment office with MAG, and they're able to conduct capacity assessments to manage property or whatever. There's people who are clinical ethicists who can also do these things, but they're not able to do those things as clinical ethicists. So there's nothing about being a clinical ethicist per se that makes one trained or have the expertise or the scope to do this kind of direct emotional or psychological intervention. And that being said, we weren't sure whether to put this line in, but I mean, I think there's an extent to which we're not even, although I just said, we admit that some people could do this. I think we're just curious or skeptical or unsure even what the claim is. Like, is the idea that there is an independent and well-defined psychological phenomenon of the psychological constituents of moral distress that somebody could have expertise in dealing with? I mean, if such a thing exists, I don't know where one would get that expertise. Certainly, it's not anywhere that I've ever looked. There's a lot more we could say about this, and probably this is the slide that we are most passionate about, but we'll go say some other slides.
Okay, so the last 2 or 3 slides, we're considering like what would be some conceivable ways in which one could address again at a clinical level, at a case specific level, moral distress on the part of clinicians, address moral distress in the traditional sense. So we want to now kind of do a parallel consideration for addressing moral distress in the expanded sense, again, not at the systems level, but at the case level. So just to recall or to rehearse our understanding of the newer expanded sense of moral distress, It includes, we think, basically a normative judgment that one's in an ethically challenging situation where something needs to be done. So we're in a situation where there's a moral problem and we've got to do something, even though might not know what it is. And like in the traditional sense, an accompanying or associated emotional or psychological experience of distress. So in a way, a lot of the claims here are similar. So just like in the case of moral distress in the traditional sense, for moral distress in the expanded sense, discussion with an ethicist could lead a clinician, a distressed clinician, to revise her normative judgments in a way that alleviates her distress. But for the same reasons we said above, we don't think this should be the goal of clinical ethics interventions in general, except for when there, as Dave said, when there are some like extremely eccentric or not, I don't want to say, but silly beliefs. And again, another way to target this, to target distress in the moral distress in the expanded sense would be to try to specifically address the emotional psychological state. But again, just like in the moral distress in the traditional sense, that's not something that a clinical ethicist is equipped to handle in virtue of being a clinical ethicist, although she may be equipped to handle it for other reasons. Now, we do think that clinical ethicists are appropriately involved in cases where clinicians think that there's an ethically challenging situation that requires a resolution, and that clinical ethicists are appropriately involved by supporting the stakeholders involved, clinicians, maybe family members, substitute decision makers, or patients, by supporting deliberation that's aimed at coming to an ethically justifiable resolution or response, right? And this is the sort of really I think sort of traditional understanding of the primary goal of clinical ethics, right, is to support people in ethical deliberation, to support people in sorting through their options, evaluating their options, considering how ethical values interact with or relate to the options on the table, and helping people think through in a structured way what are some potential ways of going forward. But that's kind of the only specific method that we can see of a for clinical ethics to address or respond to moral distress in the expanded sense at the case level. But we think there's some important caveats to that.
Yeah, and I guess just the halfway concluding thought here is that we do think it's plausible that an ethicist doing the ethicist job might alleviate moral distress, and it might alleviate moral distress on either. I mean, it's much less likely to on the original traditional sense of moral distress, which we also think is the more important moral notion to be hanging on to for many reasons. It's conceivable that even on that stricter definition, there are circumstances in which a clinical ethicist doing what a clinical ethicist can appropriately do will alleviate somebody's moral distress. It's more likely that a person's moral distress will be alleviated through clinical ethics interventions when the phrase clinical moral distress is being used in this broader, looser sense. But even then, it's only as an indirect and contingent result of what the ethicist is doing. It's not like we have, at least as far as we can tell, although we hope to be corrected if we're wrong, we have nothing to offer that would be anything more than an incidental, indirect, and contingent method for alleviating moral distress. And anything that loosely connected to what we do doesn't seem to us like it's something that we should appropriately be claiming expertise with respect to or anything like that. I mean, like in a nutshell, to put in as simple terms as possible, like if somebody comes to us with a moral problem, we can help them try to work out the solution to their moral problem. Is there any conceptual or empirical reason to think that that will alleviate their moral distress? No, it might. But they could be wrong and feel moral distress, or there really could be no options and they're right, and we might not be able to help them, or we might not be able to address the underlying psychological state, and yada yada yada. There's nothing that we can conceive of at our disposal that gives us any sort of position or expertise concerning sort of the management of moral distress per se. And so I guess that brings us to the issue of what legitimate role, if any, do we ethicists have in managing moral distress?
And in a way, this sort of we kind of touched on each of these first 2 points in the last 2 slides. So we think that the sort of the primary case of ethicist expertise is supposed to be in addressing the underlying moral issues. So we think at a systems level, ethicists may have expertise that can be used to address the systemic or organizational or structural level causes of moral distress. So we think that ethicists are appropriately involved in those discussions, but it's worth noting that we've been focusing on the case level. We've been focusing on the sort of unit of moral distress, or the individual clinician unit of moral distress rather than systems level. But we think ethicists have a role to play in addressing the systems levels issues. But again, that will only address moral distress in an indirect and contingent way, because the target of the intervention is the underlying moral problem or the structural problems rather than the distress itself. And adequately addressing the system level problems won't necessarily resolve the moral distress. It will depend on the underlying moral beliefs of the clinicians involved. We also think that ethicists can be involved in responding to challenging moral issues at the clinical level, again, which we've been focusing on. But again, as Dave said, we think that this will only indirectly and contingently address moral distress, because again, the target of the intervention is the underlying moral problem. And whether or not the distress gets resolved is, again, contingent on the characteristics of the beliefs and maybe of the sensibility and personality of the clinicians. And I think the other thing that we wanted to note was that we don't mean to be saying here that that clinical ethicists should sort of seal themselves off from reports of moral distress, or when someone calls and say, like, I'm distressed morally, that they should refuse to talk to them. We actually think that clinical ethicists should probably treat reports of moral distress as preliminary but defeasible evidence that there's something going on that may require a clinical ethics intervention, right? So it's not decisive evidence, right? Because someone may experience moral distress or believe themselves to be experiencing moral distress in the traditional sense or the expanded sense, but it may nevertheless turn out to be the case that there is no underlying moral issue if the beliefs are incorrect. But that having been said, because we think that sort of all of our lives take place against the backdrop of the assumption that most ordinary people have a reasonably sound sort of sense of morality, that it makes sense for clinical ethicists to treat reports of moral distress by clinicians as a kind of alert system or warning system that something morally problematic is happening that needs to be addressed.
Although, I mean, it may be something that needs to be addressed that absolutely cannot be addressed by us, So to conclude, I mean, we think this is a reflection maybe of a larger problem, which has to do with the scope and the appropriate exercise of clinical ethics practice. I mean, the discipline for those who worry about such things, like what is it that we're all doing all day when we're working as clinical ethicists. There's a lot of, in the literature and also just in casual conversation with our colleagues, there's obviously a lot of uncertainty and disagreement about what it is that we're supposed to be doing. And the issue of moral distress is made more complicated by the fact that it has moral in the title. So it's a little bit weird if somebody comes to you and says, like, oh, moral distress, you're the ethicist, like it can feel odd to, and we're not proposing you say we don't have anything to do with that, but it would feel very odd to say that. Like, if you, the ethics person, doesn't have anything to help with regarding moral distress, then like, what exactly do we have you around for? Which is a very good question. And so, yeah, I guess this is part for us of like a bigger investigation or thinking about what it is that we're supposed to be doing and how it is that we're supposed to be characterizing what it is that we do.
And I think, I don't want to go on too long because, Angel, you can correct me if I'm wrong, but I think we're supposed to be stopping momentarily, the talking by us part of it. But I guess I would want to note 2 things. One is that we haven't said much here positive about what we actually take to be the role, but I think that part of what we've said about the ways in which we think we can legitimately address moral distress, albeit in an indirect and contingent way, we think that's probably where we should be at least starting to look for the kind of core of the scope of clinical ethics, namely supporting and participating in structured deliberation about the right thing to do when there are moral problems. And I think the other thing I just want to emphasize as we close is that, and I know we've said this a number of times, but I want to emphasize it, we're not saying that clinical ethicists should be sort of like unwilling to talk with people who are experiencing moral distress.
Of course, yeah.
We think there are a lot of, many clinical ethicists sort of have, I don't know exactly why this is the case. Some of it maybe because of the specific skills cultivate of active listening, for example, and maybe just in virtue of something about the personalities of many people who come to the discipline, they may be good people to talk to. And it's totally fine and good for colleagues who do difficult work together to talk with each other. And we also think there's some things structural about the clinical ethicist role, at least in a lot of organizations, where the ethicist is often more or less independent of particular teams, right? They may have an office that's not on the unit, and you can go talk to them without everybody on the team hearing or knowing or seeing. And that is, I think, a comfort for some people. And that's all fine. We just want to emphasize that none of that really has to do with the specialized expertise of clinical ethicists, right? These contingent features of the roles and of many of the people who end up in the roles, but aren't sort of indexed directly to the practice itself.
I think it's plausible that I don't even know what this means, but on average, like clinical ethicists might be like better people to talk to when you're feeling bad than a lot of other people or whatever. Like that's fine. You just can't build a profession out of that. Like it can't be our professional standards and our practices can't be based on the fact that like we on average are like better people to talk to, even if that's true, which is hopefully true.
And on that note, I'm wondering if we want to move to the discussion period. Right. Sure. So thank you. Thanks so much for that presentation. Spoke to me today. This is something that I think the role clarity piece in particular that I think we try to do a lot of thinking about as ethicists. So this is a really great start to the discussion. We have some questions and comments in the chat. So for those watching on YouTube, you can type your question into the chat. Or if you're not logged in or want to send a question anonymously, you can send an email to lori.balchuk@utoronto.ca, and that information email should be in the chat as well. I'm going to start with sort of the first comment that we have, and I'm going to add on a question to it. So Kathy says, with respect to sort of the feelings about doing the right thing, she says, sometimes healthcare professionals' own bias or morality guides them to what they think is the right thing, but it could be standing in the way of doing what the patient thinks is right for them. So I understand that comment to be sort of moral distress potentially arising from a tension between clinician values and patient values in a situation where the values that I think ought to matter are the patients, because it's their decision to make in that clinical situation. So my question is that an example of moral distress in the expanded sense? Is this something that is more like moral injury or maybe something else? And if it is moral distress, I know, so in our role as clinical ethicists, often the role clarity piece around which values ought to take priority in certain situations is one thing we offer as clinical ethicists. So I wonder if that might be an example where something like role clarity can help clinical ethicists to address moral distress, if it is that, in such a situation. So.
I'll rant, since you're muted, Jeremy, I'll just talk first, I guess. That's a very interesting question, collection of thoughts. I guess a couple things that come to mind. It seems like certainly in the expanded sense, at the very least, that could constitute an instance of moral distress. It seems like not impossible that it could constitute an instance of moral distress in the narrower sense, depending on exactly how the details were worked out. But I think it's a nice example of why appropriately resolving, again, it would depend on exactly how you dress up the details of the case, but appropriately resolving a moral issue, like it could or might not alleviate whatever the involved feelings of distress were. Like if you have a circumstance where it might be that there's a circumstance where the clinician is right that for whatever reason, maybe that there's a patient in front of them and they believe the right thing to do for the patient is X, and the patient's family is advocating for some other thing, and maybe the clinician's even aware of certain facts about the patient's own values or whatnot that they think ought to be motivating and driving the conversation and so forth. And who knows, depending on how things get appropriately worked out, that might make the clinician feel better or worse, right? Like we don't know. And similarly, the clinician could be wrong. And the clinician, if we believe that there is an underlying moral matter and that we might clarify things and we might resolve the case by helping or by explaining to the clinician why in this circumstance their own values have to be deprioritized, and what matters is, again, it really depends on the details. But that it might make the clinician feel much, much, much worse than they started out feeling. And so we might have done our jobs excellently and everybody might feel worse at the end. And that's okay. Like, I think we think that's okay. I mean, it would be always better, all other things being equal, if everybody always felt great. But
I think it's also just worth noting, and again, I agree with Dave that a case like this could be fleshed out in so many different ways that you could kind of make it work for all kinds of different positions. But I think one thing it highlights is for lack of a better word, the kind of like objective component of the traditional concept of moral distress, right? So the way I understood the case, it's certainly possible that a clinician in that situation could believe that she's in a traditional moral distress situation where the rules of informed consent are systematically preventing her from doing what she knows to be otherwise the right thing to do. But if it's actually the case that, all things considered, we should do what the patient wants anyway, then she may be very distressed by this, and she may understand herself to be experiencing moral distress. But if her belief is wrong about what the right thing to do is, then on the traditional narrow, strict conception, she's not actually experiencing moral distress. She's experiencing distress and mistakenly believes it to be moral distress. So I think in a way, I think it highlights the usefulness, or maybe the need to get clear on what exactly we mean when we claim that that a particular case of distress is moral.
So our next question, I think, maybe speaks to that distinction between sort of the narrow and expanded sense. So they say ethicists may be experts in how to think. Ideally, we deliberately balance conflicting arguments in a fair and unbiased way, hopefully. Could we train others, like frontline clinicians, to think this way? In my understanding, moral distress and moral injury can be the result of thoughts that spiral out of control and fester, almost arguing fairly with oneself, which adequate ethics training and ethics tools can possibly stop the spiral. And yes, how does that sound? And add sort of the caveat that, of course, some people are better at this than others in ethics, and that training might be required. So I wonder, is that an example of sort of, or how, does that speak to maybe the last response you gave? I think you might be able to expand on it.
Just so I understand the question, though, is the idea like if we help people become more adept moral reasoners, would that then make them experience less moral distress, something like that?
I think so. So if they have the kind of training that we have.
I doubt it. If anything, it might. I mean, the more I would suspect, the more. I mean, I have no idea, but I would suspect that the more morally attuned one is to the many sources of wrongdoing and hardship in the world, the more one will just see the. No, I think it would make everything worse.
I think the other one thing I want to know, just the way I understood the description of the kind of like the psychological description of moral distress, like a kind of spiraling out of control, like these thoughts that that you can't really control. Like you just start obsessing over the moral problem. It strikes me as though to the extent that clinical ethicists are sort of skilled or experts in like moral reasoning or something like that, that expertise, whatever it is not going to be expertise in bringing somebody out of that kind of like psychologically pathological, that pathological mode of thinking, like that kind of description, reminds me more of something like, what would be needed to address that? I don't really know, but it's something more like, like DBT or, where therapeutic methods that are aimed to help people interrupt and respond in a more like productive way to maladaptive thought patterns. But that doesn't have too much to do with like, we're supposed to be good at like moral inference and stuff like that, right? The problem, it just sounds to me like on that description of the experience of moral distress, it's not like a problem of like messy moral reasoning. Again, it's like a psychological, emotional experience that is unpleasant and disruptive to one's life.
And I think this next question, I think you answered it, but you might want to reiterate. So they said if an ethicist is trained to handle moral distress because they have training as a registered psychotherapist, if it would be appropriate for them to apply this expertise to their role as an ethicist.
That's an interesting question. I mean, so, I mean, I think it would be inappropriate, but that's because Jeremy, I'm actually curious to get your thoughts. I mean, I have an interest in a very boundaried way, carving out the appropriate disciplinary scope of clinical ethics, and then saying that when people are operating as clinical ethics, as clinical ethicists, they do the things that are within their scope. That wouldn't stop somebody from, having a side practice or something like that as a psychotherapist who specialized in working with people who'd experienced various kinds of, moral injury or whatnot. But I think it would further lead to scope confusion to have people, while operating as a clinical ethicist, deploy those kinds of skills. Personally, it's a great question though, because to me it's like the surgical thing. Like if somebody's a surgeon and a clinical ethicist, should they, while they're wearing their clinical ethicist hat, do surgery? And I'm like, well, I mean, not if there's anybody else who can do the surgery.
Yeah, I mean, I think for the most part, I'm of a similar mind. I mean, I think, not that I know a great deal about psychotherapy, but my understanding is that it would almost be, if you're a trained psychotherapist, it might almost be difficult to talk to people to people who are in distress without deploying in some aspects of the conversational techniques of psychotherapy. I don't know if that's right or wrong, but that would be my hunch. I wouldn't want to say like that is wrong for you.
No, fair. That's smart. No,
to sort of like use these things. Now, I don't think it would be a great idea to say like, okay, well, maybe let's just do 20 minutes of psychotherapy and then we'll come back to the moral stuff. Like, I feel like that would be role-wise, that would probably not be great. And
you're right. Yeah.
Yeah.
It's easier to accidentally do psychotherapy than to accidentally do surgery.
Depends.
So my understanding, do you think, so there is value in keeping these roles separate as much as possible? Is that what
or unless, I mean, and we thought about including a slide on this. I mean, there could be a position according to which clinical ethicists should lean into this, right? And actually, this should be an area where actually ethicists do develop actual expertise. Like maybe all clinical ethicists should be registered psychotherapists with particular focus on this stuff. And I mean, somebody could think that.
Yeah, I think the only thing about that is like, and I know you weren't saying like that, is that that's a potential position. I guess one thing I'd say that is like, it would seem to me that our claims, our conceptual claims, would still stand. That like, suppose that as a whole, suppose there was like a college form and they said, from now on, if you want to call yourself a clinical ethicist, you've got to be a registered psychotherapist. Even then, that would represent sort of the right way to understand what happened there would be as a melding of two disciplines. And it would still not be in, well, yeah, I mean.
I don't know. Yeah, but who cares? I mean, but imagine you could do it though. Like imagine you could, at the level of emotional and psychological intervention, make people feel better through deploying psychotherapy techniques. And then imagine we all said we were going to do that in the moral domain. And we got, rather than it just being that we were like good people to talk to, and like luckily no one's calling me on the fact that I don't actually know what I'm doing, and like more often than not people claim to feel better afterwards. But if we actually develop, I mean, again, I think that for 1,000,001 reasons this is a very bad idea, including the fact that it would take us away from the actual work of moral deliberation and stuff. But I'm just saying, I could at least imagine that being a coherent position somebody could put forward.
I know we're at 5, but maybe we would take just a couple more minutes because we started a bit late for sort of one more question, and maybe we can end on sort of what that domain of clinical ethics is, what carves out that role, particularly in responding to moral distress, and that might be in the narrow sense and thinking about sort of some of the institutional work that can be done. I know you mentioned it earlier and alluded to it. I'm wondering if you could just say a few concluding thoughts about what the role of clinical ethics can be. Or ought to be.
Jeremy, I don't know if you, I mean, well, if you want to go first or second, I don't.
Is the just for clarity, like, is the question specifically about what sort of, where do we land on the issue of the relationship between clinical ethics and moral distress, or more general? Okay, specifically. Yeah, I mean, I think what we said sort of in the latter half sort of represents the rough position we're at, which is that the sort of primary work of clinical ethics is supporting in a variety of ways ethical deliberation in morally challenging or morally fraught situations, both at the systems level and at the clinical level. And we think that doing that well can or will in maybe in many cases indirectly and contingently diminish, decrease, or alleviate moral distress. But we don't think that the ad for clinical ethics should be that it will alleviate moral distress, because we don't think there's no conceptual guarantee, there's no conceptual or empirical guarantee that doing clinical ethics well will reliably alleviate moral distress.
And I mean, I would say I'm probably even, you sounded there quite sort of cheery about the likelihood of it happening there. I don't know, maybe it's just the way you said it there, you thought like maybe it would happen fairly often. I probably think it, I mean, you know, I'm not saying that like when people talk, you know, when I do ethics counsel, it's not like everybody's miserable or something like that afterwards, but you know, I just don't, I really am skeptical about there being any reliable association whatsoever about appropriate clinical ethics consultation and people, you know, their experience in moral distress being diminished or going away. I mean, I think the most important thing, and I think this goes back to a role that at least I think is an important role for ethicists to play in their clinical and in their institutional practice, which is as the role of a kind of advocate for change. I think that, to go back to the sort of flags or alerts thing, I think that there is lots of legitimate moral distress. And I think more often than not, it is the result of things that are outside of the control of the people who are experiencing moral distress, and very often even outside the control of the institutions in which those people are working. And I think that it is within the appropriate scope of a clinical ethicist to advocate for organizational level and systems level and legal change on those matters. Now, the reason to do that is not because it will alleviate, it's going to make people feel better, but it's because, you know, people's sensitivity to wrongdoing draws our attention to systems and organizational and legal level wrongdoing. And those are things that we should want to change for their own sake. And so, but, you know, a happy downstream consequence of us making systems and organizations work better or having, you know, more just and better laws is that people will, in theory, feel better.
Thanks, Dave. Thanks, Jeremy. So it's time to draw today's seminar to a close. We still had a few more questions and comments that we didn't get to, but what we'll do is we'll send those to you so you can have those comments. And I will take the liberty of inviting people to reach out to you if they want to continue the conversation. They can do so via email. So I have a couple of announcements to make before we thank our speakers. Our next seminar will be on Wednesday, October 6th, which is next week. Rebecca Greenberg, Nipa Chowan, and Jessica Foss will be discussing pediatric decision-making in the pandemic's fourth wave, reconsidering paternalism. To sign up to receive the weekly seminar reminder emails, please send an email to jcb.info@utoronto.ca. And for the CSB students enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. And finally, Dave and Jeremy, on behalf of all of us, thank you so much for your presentation today. Well done.
Thank you.
Thank you very much. Thanks, Angel.
Bye, everybody.